Always so excited whenever we have Professor Sakaris over here to speak. And he's Director of Chemical Pathology at Melbourne Pathology, Australia, and Associate Professor in the Department of Pathology at Melbourne University. He has been the chair of the RCPA QAP Chemistry and Key Incident Programs and is an examiner for the AACB and the RCPA Faculty of Science. He has been the chair of the IFCC Committee on Analytical Quality and a member of the IFCC Committee on Reference Intervals and Decision Limits. But he's been a repeat speaker, so we've had him here for fertility and lipids and oncology markers. So, and he's been super generous with his time and expertise. So very excited to have him back to talk to us about anemia.
Thank you, Perlene and Sam Sakaran for inviting me. I have to admit this topic was a little bit more challenging than usual because I'm a chemical pathologist, not a histopathologist. But as you discover, there's a lot of biochemistry in the investigation of anemia. So I'll focus on what anemia is, but also talk about these various tests and how they're useful in working up anemia. So anemia is a condition where you lack enough healthy red blood cells to carry oxygen to the body's tissues, and that can make you feel tired and weak. So there are symptoms that the patient might complain of: fatigue, weakness, pale skin, shortness of breath because of the lack of oxygen, or cardiac symptoms because of the lack of oxygen, or cold hands and feet because of lack of circulations, or neural problems because of lack. So they're the things the patient can complain of. And then the things that the doctor can see are the paleness, either of the conjunctiva or the palms and soles, the creases. You might be able to see that the patient's short of breath. You might be able to see that they've got cold hands. You might be able to see symptoms of the various causes of anemia. So, but there's also the issue of chronic and acute anemia. So in a chronic anemia, the symptoms are often come on slowly and they're quite vague, like the tiredness and weakness and shortness of breath. Whereas in acute anemia, due to blood loss, the symptoms may be sudden confusion or feeling faint or loss of consciousness. So you have to be careful in what sort of anemia we're talking about. But generally, anemia must be severe and significant before a person becomes noticeably pale. So you could see it. And this was a study that looked at the ability to pick up anemia through either the conjunctiva or palms or nails bed at different hemoglobin levels. And what they virtually showed was that to pick up more than 50% of anemic patients, the hemoglobin would have to be under 90 at best. That was for the pregnant women. But in children, they might have to be even lower than that, 70 or 80, before you've got a 50-50 chance to pick it up by looking at the child. So it's not something you can pick up clinically easily. Now, the causes of anemia can be classified in different ways. So you can lack number of healthy red cells because you're losing them, because you're not making them, or because you're breaking them down more often. But generally, the classification of anemia that we use is this based on the mean cell volume, or the size of the red blood cells on the film. And so if the mean cell volume is normal, the red cells are normal size, then it's usually one of these causes. If the mean cell volume is small, it's microcytic, then it's usually one of these causes. And if the mean cell volume is over 100, then it's usually one of these causes. So that's our way into, once we've found a patient with a low hemoglobin, what are the likely causes? Well, whenever we measure a hemoglobin, we've got the MCV, what usually we do. But we've skipped over an issue about what is a normal hemoglobin. So if you're going to do a full blood to diagnose anemia because clinical signs aren't as reliable, what is a low hemoglobin? And there's various factors that determine what a normal hemoglobin is, like the gender of the patient, their age, the country they're from, and the clinical situation that they're in. And this paper looked at, generally it didn't make much of a difference which lab you were at, the mean hemoglobin was the same. It made a little bit of difference which country you were from. So India and Thailand had lower hemoglobins, which you could imagine are either due to iron deficiency or thalassemia. Generally, men have a higher hemoglobin than women, and hemoglobin changes with age. It's lower in children than in adults. So all of these factors, and we know that clinical conditions, so hematology patients tend to be anemic, injured patients can often lose blood, oncology patients are often anemic. But, you know, one of the things that probably doesn't vary much is the method. The methods are fairly constant. This is from the Nordic study of the average hemoglobin. It's generally the same regardless of the instrument or the country. It's a very well standardized test. But regardless of the country, men are higher than women, and that should always be the case. It's hard to know what happens with aging, and here in the Nordic study, they found that hemoglobin might rise slightly in women, and it might fall slightly in men. So they're interesting questions. Now, so what should we use for a normal hemoglobin? In Australia, 50% of labs use 130 to 180 gram per litre for men and 115 to 165 for women. And the others use a whole lot of different numbers. So if you compare the Australian studies with, say, the Nordic studies, they're slightly different. And with the UK recommendations, 110, 133, they're all again slightly different. So they're really, it's a problem to know exactly what a normal hemoglobin is. We did a study of a few million results from laboratories using indirect methodology and found these trends for hemoglobin, that hemoglobin was fairly constant until you got to about age 70 in men and women when it fell. And so, you know, this is the what hemoglobin reference intervals really should look like according to aging. Now, because hemoglobin falls in the elderly, regardless of which method you're using, that was called to this Sysmex, because hemoglobin falls with age, the prevalence of anemia according to the single cutoff, say 115 for women, rises almost exponentially once you get over the age of 70. So if you're using a cutoff 115 for women, then 30% of women would be anemic in their 90s. If you're using a cutoff 130 for men, then 50% of men would be anemic in their 90s. So it's a bit of a challenge to know what the reference interval is in the elderly. Same with children. I mentioned that hemoglobin's lower in children. And so if you use the adult reference intervals for children, well then, you know, the majority of them would be anemic. So in the elderly, when they've looked at these issues, there's a high, as I said, like 35% of elderly patients might have low hemoglobins or hematocrits. Okay, now we've said that the classification of anemia should be according to microcytic, macrocytic, or normocytic. So here is a whole lot of children who had hemoglobins below 115, and what are their MCVs? And you can see the lower that their hemoglobin becomes, the more likely they are to have low MCVs, so microcytic. And generally speaking, the dominant category in severe anemia in children is a microcytic anemia, and very few are macrocytic. In pregnancy, women between 3 and 42 weeks gestation, again, the trends are, once you get severe anemia, the trends are it's mainly microcytic with very little macrocytic, quite a bit of normocytic. What about non-pregnant women? Again, you can see that in the severe anemia categories, it's mainly microcytic, but we do have macrocytic and normocytic anemias. What about in men? In men, normocytic anemia is much more common than microcytic anemia or macrocytic anemia. And then in elderly women, now we're seeing the normocytic and macrocytic being much more common than iron deficiency. And same with men, normocytic and macrocytic are much more common than microcytic, such as iron deficiency. So that was just to give you a feel that those categories of microcytic, normocytic, and macrocytic vary according to age and gender. Now, when we talk about children, well, what do you mean by children? How, in terms of hemoglobin, what should the cutoff be for a child? Is it age 12, 14, 15, 16, 17, 18? It varies from lab to lab. So we're not even sure what a child is, let alone what their normal hemoglobin level is. Now, the problem with children is generally hemoglobin falls in the newborn and then gradually rises until puberty, when it plateaus in women and it rises in men. And that's much the same as creatinine. So here's some data that we had in our laboratory that shows the same trend. Very high hemoglobins in the neonates. And then once that neonatal period's fast, the hemoglobin rises almost linearly until puberty, when men's hemoglobin rises and women's hemoglobin plateaus. The men's hemoglobin rises because of testosterone. What about pregnancy? These are just some reference intervals by trimester from different labs, and there's not a very good agreement on what a normal hemoglobin is in pregnancy, but generally we say the first trimester hemoglobins might be a bit higher than the second trimester, and we're not really sure about the third trimester. Well, there's been a lot of studies, even recently, about what hemoglobin does in normal pregnancy, and generally it does vary continuously to a nadir at about 28 to 30 weeks, and then it rises. So it's very difficult to set reference intervals in pregnancy. This is just some of our own data, which shows very much what Corey Marcus had shown in this study. Just one last point about reference intervals. Reference intervals are based on healthy population, and clinical decision limits are something different. We'll touch on that again soon. So what I've been talking about is what is the reference interval for hemoglobin, not what the clinical decision limit is. And generally the WHO have defined not only what a typical reference interval should be, but they've also defined what mild, moderate, and severe anemia is in each of these age groups. But these are clinical decision limits. They're not to do with health. They're to do with what is moderate and severe disease. Okay, now that's on that background of hemoglobin and microcytosis and everything. I'm going to run through some topics for the biochemical interpretation of anemia. So first of all, the most important one, the most common cause of anemia worldwide is iron deficiency. So here's a 4-year-old who's got anemia. It's microcytic. The MCV, which is normally 75 to 87 in children, it's a bit lower than adults, is 60. The cells are unevenly sized. So this red cell distribution width tells us how uneven. So whilst the cells are small, they vary in size from very, very small to slightly small, if you like. So looking at this, you'd say 4-year-old microcytic anemia. Well, we've said the parameters are consistent with demonstrated iron deficiency. However, consider thalassemia. So here was this boy's iron studies, and he had a ferritin level, which is the pathognomonic sign of iron deficiency, of 11. Now, 11 is low, but it's probably not the lowest most of you have seen. And the other things too, generally in the iron studies, which we'll discuss in more detail, the transferrin is usually higher in iron deficiency. The iron levels and the saturations can be low. So this is sort of a mildly iron deficient pattern. Now he was replaced, given iron, and over the next year his ferritin came up to 26, which in Australia we consider normal for children. But his full blood didn't change at all. He was still severely microcytic. His hemoglobin improved a little bit, but he was still severely microcytic. And that's why in that initial full blood it said, even though it's likely to be iron deficiency, you have to exclude thalassemia. And so this patient had a hemoglobin electrophoresis that year later, which found elevated levels of A2 and hemoglobin F and consistent with beta thalassemia trace. So always, particularly when anemia or microcytosis is severe, it's a general rule. If something is really severe, it may not be due to one cause, it may be due to multiple causes. And so you can't assume anything, especially in a child. So here's a woman, 41 years old, and she's got a low ferritin, which is iron deficiency, and she's got a high transferrin, which you'll see in iron deficiency, and she's got this ridiculously high iron level. Now, high iron levels generally due to ingestion of iron or due to iron infusion. So this patient was diagnosed with iron deficiency, and for some reason the doctors decided to take the blood after the iron infusion. And generally you'll need to wait at least a week after the iron infusion if you're going to get any sort of meaningful results for saturation, although the ferritin may be reliable. So that's just a warning regarding those things. So let's say serum iron. We're going to go through each of the elements of the iron studies. Serum has 0.1% of the body's iron, and virtually all of it is bound to the transport protein transferrin, the transporter of iron. Low levels of serum iron could be due to iron deficiency, but they can be just due to other things like inflammation or diurnal variation, which we'll cover. High levels may be due to iron ingestion or iron infusion or other sources of iron, so the release of iron from dying red cells or the release of iron from dying liver cells. Or the iron level can be high just because there's a lot of transferrin around transporting iron. Here's a 21-year-old woman. Now we're moving on to the transferrin level. She's 21 years old. She's got heavy periods, and she's got an elevated transferrin level. It seems back in 2012, she didn't have an elevated transferrin level, and now she does, even though back in 2012 her ferritin level was lower. Well, over the last 5 years, she's really become a woman with high levels of estrogen, and she's got mild iron deficiency. So again, here the high level of transferrin is due to a couple of different reasons. So transferrin is made by the liver to transport iron in the blood. It has 2 binding sites per molecule. It is also known as the serum total iron binding capacity. Come to that. Low levels of transferrin may be due to iron overload when you don't want to transport protein, or the inability to make the protein transferrin because of protein malnutrition, protein loss, or inflammation. High levels of transferrin are either due to iron deficiency or the estrogen, such as the pill or pregnancy. So this is transferrin. There's 2 iron atoms there. So transferrin has a molecular weight of 80,000. You can work out that 1 gram of transferrin is equivalent to 12.5 micromoles of transferrin. And since there's 2 iron atoms per transferrin molecule, that's 2 times 12.5 or 25 micromoles of iron per ferritin molecule. Therefore, if you've got a transferrin level of 1 gram per litre, it's equivalent to 25 micromole per litre of iron in binding capacity, and 2 grams per litre is equivalent to 50 micromole. Now, transferrin saturation, normally the transferrin does not carry 2 atoms. It's lucky to have 1. So normally it's 10 to 45% saturated. When it's empty, it's likely to be iron deficiency or diurnal variation or inflammation. When the transferrin saturation is high, it's either due to that ingestion or infusion or that release of iron from tissues. So you can see here this patient had a transferrin level of 4. 4 times 25 is 100. 10 divided by 100 is 10%. So 10% saturation was what that woman had, which was borderline. Now, even though the reference interval starts at 10, in Australia we have an upper reference interval of 45, which is not a reference interval. It's actually a clinical decision limit, which has been set by the College of Pathologists. And we'll also touch on this lower limit for ferritin, which is also not a reference interval. It's a clinical decision limit. So in Australia, we had the guidelines from our college that said transferrin saturation greater than 45% with or without elevated ferritin is an elevation. And that was because of studies like this that showed that if you had hemochromatosis, you tended to have saturations above 45%, whereas if you had no mutations of the hemochromatosis gene, that's the H63D or the 282Y gene, so in this wild type, the saturations tended to stay below 45%. So the upper limit for saturation is there as a sensitive detection for hemochromatosis, nothing to do with iron deficiency. Okay, so here's a 21-year-old girl. She's got low iron saturation. She's got a normal ferritin level and a normal transferrin level. So what can cause a low saturation? If you remember the slide that I put down before, you might have put together that a sample taken at 5:20 in the afternoon may be affected by diurnal variation. And this has been known for 70 years, that ferritin level, the iron level or the saturated levels falls, and it's got its nadir at about 5 o'clock in the evening, and then it rises back to normal. It doesn't have that diurnal pattern if you're giving, if a patient's deficient or they're giving supplements. And here's just some data from our lab. So the likelihood that you'll get a serum iron below 10 is twice as likely if you take the sample in the afternoon compared to the morning. So that needs to be considered. And that's one of the reasons why serum iron and saturations are so lousy, because they can just be affected by the time of the day. Okay, the important test is serum ferritin. And serum ferritin is a very big molecule, much bigger than transferrin. It actually consists of these 24 subunits of the ferritin protein, which form a sphere inside which is stored iron. Now, when we measure the serum ferritin, it's usually not these full packets of spheres of iron. It's usually just the apoferritin, the empty proteins. But it still reflects ferritin production, which is triggered by iron stores. So serum ferritin, low levels of serum ferritin can only mean one thing: iron deficiency. But high levels of serum ferritin can be due to iron overload, inflammation, hepatitis, or cancer, things that can release ferritin from the tissues without necessarily a high level of iron. This was the 21-year-old girl. Now, remember that this was a 30 cutoff for so in Australia we use a cutoff of 30 nanograms per mil or microgram per litre for ferritin to define when somebody's iron deficient. And that was defined by the college due to studies like this. So as ferritin levels fall to about 30, more like 20 in women, the likelihood of anemia starts to rise. With men, the likelihood of anemia starts to rise somewhere between 50 and 100 of ferritin. So it varies a little bit. You might want to think about this graph. What about mean cell volume? So here, the mean cell volume when ferritin's between 21 and 30, the mean cell volume below 83 femtoliters here is higher. It's almost twice as high as when the ferritin's 100 or 200 or 300. So there's evidence that iron deficiency is microcytosis as soon as the ferritin drops below 30. transferrin was also higher in patients with transferritins between 21 and 30. So, we don't really want to wait until everyone's clearly iron deficient before we diagnose it. That's iron deficiency anemia. We want to diagnose iron deficiency before the anemia develops. That's why we have the ferritin cutoff of 30. And here's another study, similar sort of thing, younger women, older women, or men. When the ferritin levels drop below 30, the median mean cell volume has started to fall already. So there's physiological changes even at ferritin levels of 30. And this sort of approach has been used by Corey Marcus and Seeping Low and Gorkum. And they looked at, now in their study, they found that the inflection point was at a ferritin of 20 rather than at 30. But one thing that I'd say is that, we've recently changed methods for ferritin, and we find that the inflection point using the new method is higher than the inflection point using the old method. And that's a real problem with ferritin. One of the biggest problems for ferritins is that the assays measure differently. There are actually 4 international standards for ferritin, and manufacturers vary which one they use. Hopefully they'll all be using the new one, a recombinant ferritin. They'll start it, but you can see here a level of 25 in one lab can be under 20 in another and over 30 in another. So even though we try to use the same cutoff across Australia, we know that methods are different. And really there is a pressure on laboratories to try to make sure that their ferritin levels measure the same. Just in terms of iron stores across life, this is interesting because with women, their iron stores are generally low as children, and then through premenopause, they're still low, and as soon as they stop menstruating, they start accumulating iron. Whereas with men, as soon as they've stopped growing as a child, they're obviously not menstruating, and so they accumulate iron. So men have very much higher ferritin levels than women, and women catch up in the postmenopause. And so conversely, in terms of the prevalence of iron deficiency, boys can be iron deficient, but as soon as they stop growing, it's rare for men to be iron deficient. Whereas women, as soon as they stop growing, they start menstruating, so they're always on the threshold of iron deficiency, and except when they become menopausal and they stop menstruating, and then the risk of iron deficiency drops, doesn't disappear. So here's a 1-year-old child who's got a full hand of iron deficiency, low saturation, high transferrin, and a very low ferritin level. This girl is vegetarian. And these are fairly shocking results. Her hemoglobin was 34. And it really is an awkward thing with vegan or vegetarian parents deny their children iron because they can run into big troubles. Now with children you can't easily diagnose their anemia based on, conjunctival pallor or palmar pallor or nail bed pallor. So in this meta-analysis, the last 15 years, it did not document highly accurate clinical signs of anemia. So clinically, you can't pick anemia in children. And their solution, rather than testing all children, is in view of the poor performance of clinical signs, universal iron supplementation may be adequate control strategy in high prevalence areas. Children are a really concerning issue. And this is one of the reasons, because anemia can affect up to 69% of Indian children, and really the only way to avoid that is to have nutrient fortified cereal after 6 months. Now here's a 6-week pregnant woman who's got normal iron studies. Now we use a cutoff of 20 in pregnancy rather than 30, because we sort of know that iron falls in pregnancy. But So everything looks okay. The transferrin's not high, the saturation's not high, the ferritin's not high, but and her hemoglobin at 6 weeks is all fine. And a lot of antenatal guidelines say if you do the full blood, then you don't need to do iron studies because they're not likely to be anemic. And this sort of proves the case. This patient's neither anemic or iron deficient, so she's 6 weeks. So they're fine to go through this pregnancy, or are they? At 32 weeks, remember she was her ferritin level of 29 at 6 weeks. At 32 weeks, her ferritin level was 5. The baby is very good at sucking the iron out of the mother. It's a very effective parasite. And so, the mother is now iron deficient because she's had to give up iron. Well, not only to the baby, because she's also growing a uterus. The uterus is enlarging at this stage. So is that what happens in pregnancy? And she became anemic as well. This was her at 32 weeks. She's anemic now. Her MCV is fallen, but not low. So, and that is basically what happens to all women in pregnancy. This is thousands of women that we've followed across pregnancy. And you can see that if you start off with a ferritin level of around 20, you can bet that they're going to fall well below 10 by the time they're in the 3rd trimester. So, this is a real problem in pregnancy. Now, a lot of obstetricians' attitude is, well, it doesn't matter if they're anemic and they've got low ferritins in the 3rd trimester, we'll just give them an iron infusion. But, it seems like it might have been better to give iron earlier on in pregnancy. And one of the reasons is that, there are studies that are coming out more recently that show that if maternal ferritin levels are 12, lowish, then the memory and executive functioning of the offspring is affected. So iron levels in pregnancy may affect the neurological development of children. So, really, iron deficiency in pregnancy is not just a game of numbers. Okay, my second topic is B12. So vitamin B12 is generally B12, which is this cobalt containing molecule, is chaperoned wherever it is in the body. It's a very precious resource, and it's chaperoned in the body, whether it's chaperoned by the protein intrinsic factor, the protein haptocorrin, or the protein transcobalamin. An example is in absorption. So in absorption, haptocorrin is produced by the salivary glands and binds any free B12 so that it isn't digested by the time it gets to the stomach. And then the stomach will pick up any B12 with its binding protein, intrinsic factor, and protect it until it gets to the terminal ileum, and then B12 can be absorbed. So you can see B12 is sort of chaperoned right through the gastrointestinal tract, not just by intrinsic factor. Now, what about once it gets into the blood? So if this is, let's say, a patient with a B12 level of 400. Now, the B12 in the blood is also bound to different proteins. So typically, the major part of the B12, 300 of it, is bound to a protein called haptocorrin. And the minor part is bound to a protein called transcobalamin. They used to be called transcobalamin 1 and 2, or 1 and 2. Now, these proteins, a bit like transferrin, are not saturated. So typically, haptocorrin is highly saturated, so 75% full, whereas transcobalamin, a bit like transferrin, is only about 10% full. Now, what are these two proteins doing with B12 in the circulation? So here are the different forms. Here's transcobalamin, 10% saturated, and here's haptocorrin, 75% saturated. And when we're measuring total B12, we're measuring both of those proteins carrying B12. Now, the important one is this hollow transcobalamin, which is actually what the cells can pick up to get B12. It's the active B12. And that's how cells absorb iron. So the most important fraction is holotranscobalamin. So here's a woman who's pregnant. She's got an active B12, a holotranscobalamin of 47, which is normal, and she's got a total B12 of 119, which used to be 1,199. So that gives you a bit of a clue what's happening here, a bit like ferritin. Women use up their B12 stores in pregnancy, and their B12 stores are in that highly saturated haptocorrin fraction. So this patient is actually using up their B12 stores, but still has enough available for her cells and the baby cells. And she's also used up her iron stores. So this is a paper we had in for pregnancy, and you can say that total B12 normally falls in pregnancy. Holo-TC usually is protected in pregnancy. It doesn't drop below the cutoffs usually in pregnancy. Okay, here's a 73-year-old woman who's got anemia. It's not macrocytic or microcytic. So, but the film was suggestive of iron deficiency because it's closer to iron deficient than microcytic than macrocytic. So they did iron studies, and well, yes, the patient's iron deficient, but they're also B12 deficient. Now, the important thing here to say is that if somebody's iron deficient, the more iron deficient they are, well, why are they iron deficient? Because they're vegetarian or vegan, and they're likely to be B12 deficient. So whenever you think of iron deficiency, you should also think, could the patient also have B12 deficiency? And so this patient, because they've got a mixture of iron deficiency and B12 deficiency, that's why they were neither microcytic or macrocytic, but normocytic. Here's an 86-year-old man with non-Hodgkin's lymphoma, and he's got a worsening anemia. It's bordering on iron deficient, 81 femtoliters, or microcytic. But there were occasionally hyperassegnated neutrophils, which is code for possible B12 problems. So here's this patient. Now the ferritin level is nowhere near deficient, and their active B12 is low. So this patient has got, even though they've got a very healthy B12 level, they are B12 deficient. And the reason here is because a lot of hematological tumours not only produce ferritin, but they can also produce haptocorrin and make it look like the B12 level's high when all that's happening is the tumour's producing haptocorrin and ferritin. Now this is just a little bit of a mark. I could talk for a whole hour on B12, but here's a bit of a clue. So what this is saying is that if you're waiting for hemoglobin to be deficient in B12 status, then it's going to be severe deficiency. You might wait for macrocytosis, which occurs earlier. You might look for the markers of B12 deficiency like homocysteine, methylmalonic acid, or you might measure active B12, which can tell you about these early stages of B12 deficiency. Now, before I leave B12, I want to talk about this concept of haptocorrin deficiency. So here's a 66-year-old man who's been given B12 for years, and his total B12 never gets above 150. Now, it varies from patient to patient. These patients cannot make haptocorrin like the normal patients. Normally, you can see B12 levels in healthy people of 1,000 or 2,000, and they're generally got 1 or 2 year stores. But these people who can't make much haptocorrin can only get up to 100 or 200 or 300, and effectively they've only got 1 or 2 month stores. And this is called haptocorrin deficiency. Nobody knows the true prevalence of it. My estimate is about 1% of the population that has haptocorrin deficiency. And it creates a lot of confusion because most people would say they're severely B12 deplete, but the active B12 levels are clearly sufficient. What about folate deficiency? We'll cover this one pretty quickly because in a lot of countries in the world, in America introduced mandatory folate fortification in 1998, and really, the high prevalence of folate deficiency that they had in 1994 just disappeared. Not overnight, but over those years. In Australia, we introduced voluntary fortification, which dropped our folate deficiency rates from 8% to 4% in the laboratory. But then we made it mandatory in 2007-ish, and suddenly, and now the prevalence of iron deficiency in Australia is less than 0.5%. Folate is in flour, so it's the only people that don't eat flour that get folate deficient, and that can be people like celiac disease or people that have malabsorption or hippies that eat flour that doesn't have folate in it. Okay, so here's an example of a woman post-bariatric surgery. She's obviously going to have malabsorption with that. She needs iron supplements of all sorts of things. She's macrocidic. And when we look at her, she had a homocysteine levels astronomical. And is it because of the low folate or is it because of the low B12? Probably a mixture of both. Folate deficiency is so rare, I'd say that before calling anything folate deficient, better check the B12 level. Now, another reason why you can be anemic is because heart valves through trauma can be damaging the red cells. And here's a patient who had valve hemolysis, so they're anemic. It's bordering on macrocytic. The reticulocyte count, you remember they're trying to replace those cells. The reticulocyte count is high-ish, but still normal. But, how do we work out whether there's hemolysis there? Well, we do the test. Bilirubin is a breakdown of heme in hemolysis. Haptoglobin mops up free hemoglobin, so it's undetectable in vivo hemolysis. LD is released by hemolysis. And here I just want to point out that AST is released by hemolyzing red cells as well. So you often see this hint of an AST, which is much higher than the ALT in hemolysis. So this patient's clearly got hemolysis, which is the cause of her anemia in the valves. Another cause of anemia, usually said to be macrocytic anemia, is hypothyroidism. So here's a woman who's tired and anemic. She's got a low hemoglobin. It's severely macrocytic. SARS elevated, which is interesting. So the doctor thought, if she's anemic and macrocytic, or maybe must be now in the report, it's in the hematology report, it says consider B12 folate deficiency. It doesn't actually mention thyroid disease at all. So this woman did have moderately severe hypothyroidism. So was that the cause of her macrocytic anemia? Well, no, she had B12 deficiency. It's easy to jump to conclusions just because of what the textbooks say, and that would say this hypothyroidism that's causing her anemia. B12 deficiency is by far more common cause of macrocytic anemia than hypothyroidism. So you must always exclude it. And more recent studies have sort of shown that, in hypothyroidism, they are likely to be anemic, but it's more likely to be microcytic than macrocytic. And in this study here, they said, even though you're a little bit more likely to be anemic with hypothyroidism or anemic with hyperthyroidism, the reasons are the other diseases those patients might have, like iron deficiency, chronic kidney disease, B12 deficiency, inflammatory disease. So before you assume anyone's anemia is due to thyroid, you better have done all those other tests, because otherwise you'll be chasing the wrong winner. Okay, now what about the anemia of chronic disease? What is the anemia of chronic disease? Now, I'm going to go back a few steps. Bacteria need iron to grow in our body, and that they've got two mechanisms. One is hemolysins, which are proteins which punch holes in our red blood cells so the hemoglobin can leak out. And then once the hemoglobin leaks out, they produce other molecules called siderophores. Desferrioxamine is a siderophore made by bacteria, which bind iron and can bring it back to the bacteria. So that bacteria are masters at getting access to iron in our body. So, and this is what inflammation is largely about, protecting the body from the bacteria wanting to get our iron. So here's the mechanism. So here's the bacteria. They'll punch holes in the red cells and produce siderophores to suck the iron out of the red cells. And that'll release hemoglobin, iron, and heme into the bloodstream. But the bacteria are also detected by white cells, which will send out signals like cytokines, which will send a signal to the liver to say, we're under attack. Somebody's after our iron. And what the acute phase response is to increase proteins like ceruloplasmin. Ceruloplasmin is not a copper-carrying protein, it's a ferroxidase. Hemopexin, which binds heme, and haptoglobin, which binds hemoglobin. So our defense is to release proteins which will bind all of those iron-containing elements. It also results in increased hepcidin, which tells cells not to release iron. It also decreases the production of transferrin, so the liver won't be tempted to transport iron around the body. Now, if you're accumulating iron and not transporting it, it's going to accumulate in the tissues, and that's why ferritin rises. Because we're trapping iron in our cells, ferritin rises as if it were an acute phase reactant, but it's actually not triggered by cytokines itself. So here's a 20-year-old woman with glandular fever. She's got positive IgM EBV, and she had these iron studies. So low iron, inflammation causes low iron, inflammation causes low transferrin, and iron and ferritin will accumulate in her cells. So now here the problem is we don't know whether she's iron deficient or not, because this ferritin's rising just because she's storing iron. Now, there's a guy, we shouldn't be using this cutoff of 30. That's the bottom line. When there's inflammation present, the ferritin's going to rise due to the inflammation. So what cutoff should we be using? And according to the WHO, the general guide for a woman her age is to use a cutoff of 70. 55 is less than 70. So we would say that she is probably iron deficient. Here's a man who demonstrates that case. So here he is with inflammation and a ferritin of 58. When the inflammation settles down, you can see the iron deficiency, the underlying iron deficiency. And even though his hemoglobin improved when the inflammation settled down, it didn't go away completely because he's still iron deficient. Okay, I'm going to skip through the last 4 topics. This woman, now this woman's got macrocytosis and a raised Asr. Macrocytosis isn't really a sign of inflammation. So why is the Asr due to inflammation? Well, no, the CRP is normal. So raised Asr can be due to a paraprotein. And she unfortunately had a 10-gram paraprotein there, which was confirmed with light chains, kappa light chains. So she had myeloma as the cause of her macrocytosis. And was picked up early. 5 years later, the myeloma's progressed a bit and she's still anemic and macrocytic with a raised Asr. Thalassemia. Now, this patient had a low mean cell volume with anemia, and they were wondering whether she's iron deficient because low MCV, low anemia, high IDW. Some people say that in an iron deficiency, there's a high unevenness of the red cells, whereas in thalassemia, they're all evenly sized, and so the RDW would be lower. So we'd be probably backing that this might be iron deficient. Now, she does have a low ferritin, but it's pretty unimpressive for such a severe degree of anemia and MCV. So is that the cause of her anemia? She doesn't have any hemolysis. This is the liver function test. Bilirubin's normal, AST is normal. Her B12 levels are lowish. Well, it's not surprising because remember, low iron tends to be associated with lowish B12s. And she had a protein hemoglobin electrophoresis, which showed she has beta thalassemia trait. So beta thalassemia trait, usually causes that severe, very low MCV and anemia, and you should always consider it. Sickle cell anemia is a little bit different. So here's a patient with sickle cell anemia, worked out to be sickle cell anemia. So they've got macrocytosis, severe anemia, and here is the macrocytosis due to iron deficiency or due to B12 deficiency? Well, no, obviously not. This patient's getting supplements for both of those things, trying to improve their anemia. And here's their routine chemistry, raised bilirubin, and here's that hint, a high AST compared to ALT. So this is, until proven otherwise, hemolysis. And the electrophoresis showed that she had hemoglobin S, and so sickle cell anemia tends to be associated with hemolysis and sickle cell crises and so on. Now this is a different cause of hemolytic anemia. So not a genetic cause, because here it is, it's just developed. Macrocidic anemia, very high reticulocyte sounds. So the woman's trying to replace all those red cells. They did a protein electrophoresis. She doesn't have myeloma. She did have a low alpha-2 macroglobulin, alpha-2 protein band. That's where haptoglobin runs. So if we measure the haptoglobin, bilirubin, AST, LFDH, that all says she's hemolyzing. And she was hemolyzing not because of sickle cell anemia or some other problem with her red cells, but because she's got antibodies which are sticking to her red cells and destroying them. Here's another man with severe autoimmune hemolytic anemia, and it was so bad that they couldn't even. It was a cold agglutination, so the cells all stuck together in the sample. They couldn't even examine the cells on the culture counter. And here's his pattern: low haptoglobin, high bilirubin, much more severe than the other woman, and raised AST compared to ALT and raised LD. And he had very, very high levels of antibodies. Now, my last topic is urea. And I hope some of you are wondering what the hell's urea got to do with anemia. So here's a woman who presented to emergency department with whatever that means. It probably means upper GI bleeding. So she probably had pain and a bit of hematemesis, vomiting blood. So why is that pattern there? Why is that pattern important? Here's her full blood at the same time. Her hemoglobin is normal. She's not even anemic. She's just started vomiting. She's lost blood, but she hasn't diluted the blood in her vascular space with extracellular fluid yet. She's just started to bleed. She's lost pure blood and she's got a little low volume of blood, but hasn't been diluted yet. And that's what happened to her a few hours later. The hemoglobin dived down, and it kept diving when she was in ICU. So, and her urea had gradually improved while she was in ICU, and she was starting to adapt to the fact that she's lost all that blood and getting some more blood volume to be able to clear that urea. So, well, how does that all work? Well, if you bleed blood into the gut, the blood will go to your microbiome, and the bacteria in the gut will metabolize that protein to ammonia. That ammonia would be reabsorbed back into the body and converted to urea by the liver. So whenever you bleed into the gut, you're going to have a high urea. And if your urea is 15 or so, it's likely you're going to end up in ICU. And if your urea is over 8 or 25, your chances of dying from that gastrointestinal hemorrhage have increased exponentially. So to me, the urea level, particularly in the presence of a normal creatinine, is a warning sign about GI bleeding with or without the presence of anemia. Now, some of you might have thought, well, raised urea, normal creatinine, you can see that in congestive cardiac failure and poor renal perfusion and so on. Yes, you do, but not with the normal GFR. If the eGFR is normal, it's unlikely to be congestive cardiac failure and much more likely to be upper GI bleeding. Okay, so in summary, I've sort of walked through a lot of the tests to do with iron deficiency or B12 folate deficiency and so on. So that's the simple guide. There are more complex guides available on the internet about how you should investigate all of these different causes. But as I said, I gave you the biochemist point of view. And so in summary, anemia can only be reliably detected by blood tests. The measurement of hemoglobin usually includes MCV, and this is how we classify anemia. And the biochemical investigations are important in assessing the causes of anemia. So thank you.
Well, thank you so much, Professor Karis, for this wonderful and very informative presentation. I've allowed the mic for all attendees, so if you want to unmute yourself to ask a question, please go right ahead. We already have some questions in the chat, and the first one was about active B12 and total B12. It says, can you explain active B12 and total B12? I think that's a little bit not so clear.
Yeah, the take-home message is total B12 is the sum of active B12 and the haptocorrin-bound B12. And the haptocorrin-bound B12 you think of as stores, your stores of B12. So normally when your total B12 is 1,000, you can only get to 1,000 if you've got high stores. So the haptocorrin-bound B12 is high. But the active B12 can never really get much above 150 or 200. So that's the B12 that's available to the cells. So in a way, when we measure total B12 and it's low, the question is the total B12 low because the stores are low or because the B12 that's available to the cells are low? And the B12 available to the cells is much more important than if the stores are low. So in Australia, it's a routine. Whenever the total B12 is low, we do the active B12 to work out if the available B12 is low, because that needs treatment. Low stores don't necessarily need treatment, but low active B12 definitely needs treatment. So yeah, just think of the two fractions, the active fraction, the hollow TC. Hollow TC is the same as active B12. Active B12 is actually Abbott's name for hollow TC. There are a whole lot of other companies, Siemens and Roche, that produce hollow TC assays, and that's the proper name for that form. The hollow TC is the active form, and yeah, so that's the important thing. I know that it's more expensive, and that's why we reflex from total to active, but hopefully it'll become cheaper and cheaper as time goes on, because it's the most important test.
I mean, I've seen some papers that also say that it's more sensitive than total B12.
Look, it's not 100% sensitive. Like, let's say that total B12, in terms of picking up true B12 deficiency, and you can pick up true B12 deficiency by measuring things like homocysteine and methylmalonic acid. So if you try to predict which patients are going to have raised homocysteine or raised methylmalonic acid, let's say total B12 is 60% accurate and hollow TC is 75% accurate, but it's not 100% accurate. They're still not perfect tests. We're still waiting to get the perfect test for B12 deficiency.
Great, thank you. So moving on, the next question is on inflammation masking iron deficiency. I assume it's because of raising the ferritin. Says what cutoff for ferritin would you use? I think you've quite answered that already. And then do you also suggest using other markers like soluble transferrin receptor?
Yes, that is available in Australia, so it's very useful in that setting. But again, it's an expensive test, and it's not easily available. Look, I've pointed out that the WHO uses a cutoff of 70 in adults. So if you've got inflammation and your ferritin's below 70, you're iron deficient, and if you're above 70, you're not iron deficient. I think that's a little bit tight. Like you turn 69 or 70. In my mind, for the last 20 or 30 years, what I've been doing is if you're below 50 in inflammation, you are definitely iron deficient. If you're above 100 in inflammation, you're definitely not iron deficient. And between 50 and 100, I'm not sure. So I have a grey zone of 50 to 100 rather than a single cutoff of 70. But anyway, I don't really want to disagree with the WHO.
And so then soluble transferrin receptor could be a adjunct if that's available.
Yeah, so particularly in patients who always have inflammation, like patients with rheumatoid arthritis or lupus and so on, they've always got inflammation. So you can't wait till the infection settles to work out their iron status. They've always got inflammation. So in that setting, it's useful to do the transferrin receptor. So if patients got chronic inflammation, do the transferrin receptors. And the idea there is that, when the cells are crying out for iron, they put out lots and lots of proteins on their surface to say, if there's any transferrin going past, I want to grab it first. So they make lots and lots of transferrin receptors, and some of them dissolve out into the serum and they can be measured in the blood. And it's a very good test. It is the preferred way of managing iron deficiency and inflammation. But like I say, it costs, it costs many times what a ferritin costs.
So the next question is about total iron binding capacity.
Yes.
So if we measure TIBC, does it mean we get the transferrin levels, or is it calculatable from TIBC?
Yeah. In Australia, we don't. We used to measure total iron binding capacity in the old days. Now, I'm sorry if I'm insulting people, but you could measure total binding capacity by adding iron to serum and see how much of it gets bound. So it tells you how much transferrin is there. Now, that's a very inaccurate way of measuring transferrin. The better way to measure transferrin is with an immunoassay, whether it's turbidimetric or nephelometric. And so most laboratories actually measure transferrin because it's a more accurate and precise measurement, and they convert that to total iron binding capacity. I think that if you're using the iron, put iron into serum and work out how much binding capacity there is, well, it's a cheaper way to do it, but it's a second-rate method, and you have to accept that. And I wouldn't ever convert a TIBC into a transferrin level because you're just kidding yourself. So, and there's no point. So generally, we measure transferrin, and some labs report the transferrin as total iron binding capacity. To be honest, the clinicians wouldn't. Most clinicians don't even know what total iron binding capacity means. They're looking at saturation and ferritin. Ferritin number 1, saturation number 2, transferrin number 3, and serum iron number 4. There's a good argument that we should never report serum iron on its own.
Thank you. The next one is also quite interesting. Prof. Sikaris, what is your algorithm to investigate falsely normal or falsely elevated B12 from secondary to intrinsic factor antibodies? Secondary to intrinsic factor antibodies.
Well, first of all, there's a trap in patients with pernicious anemia that if you give them B12, you can't measure the intrinsic factor antibody because it relies on binding B12. yeah, we don't really have much of that problem with intrinsic factor antibodies binding B12. It may be true with very high levels of intrinsic factor, but generally we haven't seen that problem with the assays we use. So I don't know whether I've got an answer to that question. Sorry.
Maybe it's better to measure the level of antibodies. If that's...
Yeah, look, the only thing I'll say about intrinsic factor antibodies and so on is that it is the best test. Parietal cell antibodies are the next best test. Parietal cell antibodies are very poor in the elderly. They rise with age. And so a raised parietal cell antibody in a 60 or 70-year-old may mean nothing. But a raised parietal cell antibody in a young person is as good as an intrinsic factor antibody. So maybe you could avoid doing the intrinsic factor antibodies and do the parietal cell antibody.
Oh, yeah, thanks for that. Yeah, thank you everyone for the very interesting questions and discussion. If I don't see any more questions on the chat, and we are over time, so I want to make sure Prof. Sikaris gets back to his dinner on time. And thank you so much for your time and for this wonderful presentation. And thank you everyone else for attending as well, and your consistent support of the series.